Good morning. My name is Simon Rule. I'm a professor of haematology at Plymouth University Medical School. And today I'm going to talk you through what I saw as the highlights from EHA and ASCO this year. Well, predominantly I'm going to talk about the highlights from EHA because there really wasn't very much at ASCO, and that's pretty much the pattern, I think, with a lot of lymphoma. It tends to be more presented at the EHA and ASH meetings. So let's just touch on some of those things. I'm going to start with some Swedish data. Lots of publications and presentations at meetings talk about databases, and generally what they do is they collect their hospital-based data and maybe coalesce with a number of other hospitals and they get a database. But that's self-selecting by definition because it's only relating to the patients that actually come to your institution. So in Sweden, they've got a very, very robust situation where all patients with cancer are centrally registered. So they have all the data. And this was interesting because they looked at all the patients with mantle cell lymphoma between 2007 and 2017, almost 600 patients, and actually looked at their outcomes based on the therapy they received. And they split patients into those that received high-dose based treatment, pretty much MCL2, as that's a Nordic protocol, those that got CHOP-like treatment, and those that got bendamustine-like treatment. What they showed was that those patients getting the more intensive therapy tended to do better. Obviously, they're younger, fitter patients. But then when they broke that down and adjusted for age and the time that the treatment was done, they showed no difference between the high-dose intensity therapy and actually the bendamustine-based therapy. CHOP always was inferior. Now that's interesting because it kind of implies that the bendamustine is of equivalence. I think there are a couple of caveats there. I think the first thing to say is that you're not seeing the maintenance effect. So maintenance rituximab certainly became evident and was being used widely towards the end of that data collection. So you might not see the benefit of rituximab post autologous stem cell transplant. And similarly, you don't see the benefit maybe after CHOP-based therapy. So I think that going forward, that'll look interesting in a few years' time. But interesting, just showing bendamustine possibly better than CHOP in that situation. But I say don't discount the impact of rituximab maintenance there. So let's move to some actually Plymouth-based data. This is UK data looking at almost 200 patients treated with ibrutinib at second line. So in the UK, NICE allows ibrutinib, but only at second line. So there's lots of patients getting it second line. And what we did is we looked at three groups of patients. Again, very similar to what we just saw in Sweden. We took patients who had high-dose therapy, patients who had conventional chemotherapy, and then this was the interesting group, that frail elderly who couldn't receive what you consider proper chemotherapy, if you like, based on frailty. So if we look at that cohort, the median age was 84. So that group of patients you never see in trials because they're not fit for a lot of the treatments that we can give. And what was interesting, the progression-free survival to their frontline therapy was only 4 months. Not a surprise, you can't really treat them very effectively. So a lot of these patients got chlorambucil-based treatment, for example. But when they got ibrutinib, and there's a lot of anxiety about ibrutinib in very elderly patients. Firstly, only 8% of patients actually dose reduced for toxicity, so it was well tolerated. But more importantly, the overall response rate, 70-odd%, very similar to what you see in younger patients. But the median progression-free survival was double with the ibrutinib than what they had with their frontline therapy. So showing that it's the very elderly patients that actually get the most benefit from these drugs, something that a number of us have been saying for a long time. And really, that's the group of patients where we should be shifting these drugs frontline because chemotherapy, one, you can't deliver it, and two, it's not terribly effective. So good data to follow up on that. So if we move from there to Italian data from Carlo Visco. Now, he needs to be congratulated here. He's managed to get together a coalition of many people across the world and got their data on patients who had CNS relapse of mantle cell lymphoma. Now, many people, including myself, consider that to be a really appalling outcome. But actually, when you get a big group of patients together, get big data, you can actually say something a bit more significant. Now, me and other groups had actually started using ibrutinib in these patients. So what they did here was they had 84 patients. They looked at the outcomes in those who were treated with immunochemotherapy, and then those that were treated with just single agent ibrutinib, and looked at the difference. Firstly, there were similar characteristics between the two groups, but striking differences with respect to response and duration of response. So with the ibrutinib, you're getting 72% overall response rate and over 40% CR, which is extraordinary at the single agent. But with standard immunochemotherapy, the response rate's under 40%. So highly statistically significant difference. And actually, when they took out the patients who you would consider didn't have adequate immunochemotherapy, so those patients that received treatment that crossed the blood-brain barrier, there was still a huge difference between the two. So I think that's clear that if you've got CNS relapse, a BTK inhibitor, certainly the data with ibrutinib, works very effectively. The other thing they showed, interestingly, and I guess maybe not a surprise, is intrathecal chemotherapy added nothing at all, whether that was with ibrutinib or with chemotherapy. So I think intrathecal chemotherapy is really maybe a thing of the past in many situations. So from there, there's increasing data on bad prognostic features. A number of abstracts actually at ASCO and EHA just further confirming that things like p53, high risk with respect to proliferation, blastoid morphology, that represents a bad risk group of patients. Now we know that. So again, we're seeing more data along those lines. And the Italian group, I've got a trial where they're giving chemotherapy followed by high dose transplant and then a randomization to lenalidomide or maintenance. And what they did was they looked at the young patients treated within that protocol and picked out those with p53 mutations. Now it was 20%, 16% of the patients, so quite a high number, but that group did particularly badly. Again, we kind of would expect that. But perhaps worse than you might expect. So only 50% of patients got a CR after the autograft, for example. And what they were able to show was that the lenalidomide maintenance question, there was no benefit for that group of patients. And all of these abstracts conclude with, for this group of patients, we need a new approach. We need different therapies. My view has been for a while, in young patients, you should think about allogeneic stem cell transplantation. That's controversial, but everybody's calling for new agents. But what new agents? So this is the most important abstract to me. This was Steve Le Guil from France. This was a UK-French collaboration, excuse me. So this was the final presentation of the OASIS study. So this was looking at the triplet combination of ibrutinib, obinutuzumab, and venetoclax. So the relapsed data has been presented at ASH. This was the extension and looking at 15 patients untreated. So this is frontline therapy using that combination. Median age 65, a couple of the patients p53 mutated, all needing treatment. So there were no watch and wait people in this combination. So first thing to say, the toxicity was relatively mild, and I think that's not unusual when you use drugs frontline. You tend to see fewer side effects. There was some mild liver abnormalities. There was one significant neutropenia and one bad rash. The rash was actually my patient. And it's interesting, actually, this guy, this was on ibrutinib. We stopped it, and I was so keen for him to get onto this triplet. We then reintroduced it at a low dose with steroids, and we're able to escalate back up to full dose ibrutinib and stop the steroids. So if you get a bad rash, you can actually reintroduce that drug. There's a tip for you out there. Anyway, of the 15 patients, at cycle 2, all were in complete remission. That's the first thing to say. One patient progressed. That was at cycle 4. None of the others progressed. And the patient that progressed did not have high-risk features. So the p53 patients did very well. And at the end now, so only one patient's progressed. Of those where MRD analysis was possible, and that's 12 patients, 12 of 12 are MRD negative. So we know about bad prognostic features. This group, this trial only included a few, but they all did very well. So maybe this does point to this combination of drugs. And we did see this before with the Melbourne experience, looking at ibrutinib, venetoclax, that appeared to overcome p53 as a bad prognostic feature. So perhaps this is a vision of the future. This is true chemo-free, if you like. This is frontline therapy for young and old people, well tolerated and with very good efficacy. Now, obviously, we need long-term follow-up. We need to know whether this is durable. You know, are we curing patients? I don't know. Do we need to think about consolidating the younger patients, particularly with some kind of transplantation or even CAR T-cell therapy? I mean, I think these are the questions for the future, but I think that's an insight into where I think we're going. So with that, I'll finish, and thank you for your attention.